I'd now like to introduce Denise Stahl. She is the Executive Director of the UPMC Palliative and Supportive Institute, which makes her the best person to talk to us tonight about treatment burnout, which is our topic. We'll take questions at the end, and I'd like to turn the time now over to Denise.
So more than any of what that says, it's important to me that you know that I'm a nurse. And so my nursing experience has been all in either oncology, aggressive bone marrow transplant, clinical research, and then I spent the last 15, 18 years working in palliative care, really focusing on quality of life and symptom management. 10 of those years were at McGee. And so I spent 10 whole years caring for women with breast and ovarian and endometrial cancer, really trying to deal with the symptoms that come with that, regardless of what the outcome of what that cancer was going to be. So we're going to talk about the experience of it, and the reason I'm saying that is because I don't want you to think, because I'm a palliative care specialist, that we're going to talk about dying. We are not going to talk about dying. We're going to talk about how hard it is to live with cancer and the things we can do about that. So before we do that, I want to share with you a video clip called, I'm going to pass this around. It's from Stepping Into the Ring from Nicole Johnson. Nicole Johnson is a dramatist, so what we'll see isn't real. She wrote it. She is not a cancer survivor, but it's very, very attentive, I think, to the experience. And so I'm just going to show you part of it, and if you're interested in the whole clip, you can certainly go out and find that. So I know that in that clip, Nicole was certainly talking about the experience of breast cancer, but I think that her experience of cancer, her dramatic, presentation of the experience of cancer is pretty relevant. And I think what's striking to me in listening to that is that it's all about what it feels like. It's not about the science of cancer. And there will be plenty of lectures and plenty of science. But within all of that is, what does it feel like and how do we go on? And that's what we're going to kind of focus on for our time together this evening. So if we think about why is it so hard, it's because of all of these things. It's from the very moment that it starts. And so I will share with you, interesting, it'll be on video, that I spent the summer really convincing myself and my family that I had ovarian cancer. I had a workup, I had positive tests, and I went into the OR expecting to come out with a cancer diagnosis. I didn't get that, but I was lucky. And I had all of these things swirling in my head, especially given my experience as a caregiver, a professional caregiver. And I could only imagine then what it must be like once it really starts. And so it starts from this time worry starts, it starts from the first symptom, and it never goes away, even when cancer goes away. And I think we just need to normalize that and figure out, how do we make that okay, and what do we do about it? So certainly, throughout the whole process, and I think Nicole was very eloquent in demonstrating that, there's anger, and there's worry, and there's stress, and there's sadness, and all those things, those questions there are no answers for. Why is this happening to me? Is it going to be like my sister's experience? I remember my best friend died 3 years ago. Is it going to be like that? Why did I've lived a healthy life. I haven't done anything wrong. Why is this happening? And then even that kind of moment of, okay, so this is what's going on. I'll just deal with it. And then what happens next? And then starting to feel like fighting. And how do you fight and feel energetic and healthy and hopeful at the same time? Especially when some of the treatments we offer are so difficult. So during treatment then, it changes. Like, what's the treatment going to be like? I can't tell you how many people have said to me, the treatment was harder than the cancer. And sometimes when people choose to stop cancer treatments, they feel better because the treatment is so hard. There's great purpose to that treatment, but the side effects are also really hard to deal with. And then it's kind of thinking like, people think chemo is chemo is chemo and radiation is all the same. Even though the drug might be the same, and there are typical side effects, everyone's experience is so different. But yet we're tempted to compare, and we want to learn from other people who have gone through it. And then thinking about the future, what if it doesn't work, then what? I thought I was ready for this, and I'm not. How do I continue to move forward? And then recognizing that illness doesn't happen in a silo. It would be easier, never easy, but it would be easier if it only happened to us and it didn't affect anybody else in our life. I've never met one person who can say that that's true. It affects all of us. And so we worry about everyone else while we worry about ourselves. Even in survivorship, I hear it over and over again, especially in palliative and supportive care is the new buzzword in terms of supporting people through the experience of advanced illness, that it never goes away. The worry is always there about what to expect next. That whole, they tell me I'm fine, but am I really fine? Is this just a headache or is it my cancer? I've had this headache for 3 days. Should I call the doctor? And then I call the doctor, and the doctor says, don't worry about it. You're worrying too much. Really? So how do we let that go? So one of the things we can do is recognize that no matter what's going on with cancer, we all deserve to feel well, and it is possible to feel well. No matter what the treatment, no matter how bad the cancer is, we can focus on how we feel at the same time we get treatment or when we're not getting treatment. And one of the ways to start is dealing with the symptoms and the side effects. And some of these things, like pain, for example, people say, well, pain comes with cancer. Sometimes it does. Interestingly enough, from a professional caregiver's perspective, pain is the simplest thing we have to take care of. So it shouldn't be something you keep to yourself. And we need to realize as professional caregivers that you are the expert in your pain. You know exactly what it feels like. You know how to describe it in your words. And you know what you can tolerate and or put up with and what's worth it. So you have to be the voice to really bring that pain forward and to say, I don't have to feel like this. I can feel better. There's lots of new treatments and you can feel better and not be sound asleep at the same time. But we have to know and make that pain visible in order to take care of it. Neuropathy is that nerve pain that tends to be like pins and needles, or it feels like something's on fire, or when your foot falls asleep and that feeling never goes away. We can treat that too. Some of the chemo drugs we use cause that. It's a side effect of the treatment. And even after cancer goes away, sometimes that symptom stays. And so sometimes the treatment for that symptom stays. But it really takes a big picture and looking at all of those things and kind of making a list, a tangible list, writing down, these are the things that are impairing my quality of life. And sharing that list with the people who are responsible for putting your care together, because there's lots that can be done around that, with drugs and non-drugs. Something like nausea. People think a lot about nausea with cancer treatments, and sometimes people expect it. You all are probably, in some regard, I'm speaking to the choir here, you all know that the new drugs are amazing. The things we can do for nausea have come so far. No one should have to feel nauseated. And interestingly, some of the treatments we use for nausea aren't what you would think. They're not typical nausea medicines. They're other kinds of medicines. We do things with biofeedback and meditation and all kinds of complementary therapies that aren't necessarily drug-related. But again, we can't fix it if we don't make it visible. What happens to the blood is actually quite scientific. Some of it is because of cancer. Some of it is because of the treatments. So we know that it impacts our red blood cells and our white blood cells. And we know that in a healthy person who doesn't have cancer and who has not had a chemotherapeutic agent or radiation, that those cell lines tend to regenerate on their own. But they're impaired by cancer and cancer treatment. And so we can do something about that. Sometimes it takes a drug to counteract the drug of the effect of the chemo. Sometimes it takes a transfusion. Sometimes it takes a treatment break. So there's lots of different things that we can try. But again, we can't do anything about it if we don't talk about it. And I worry that sometimes the cancer itself takes priority over the experience of cancer, and it should never be like that. In fact, it should be the opposite. The experience should take priority over the cancer. Because if we deal with the experience and we improve quality of life, guess what? You're probably able to tolerate and pursue more aggressive therapies. In fact, I mentioned earlier palliative, my specialty, the field of palliative medicine. There was a study out last summer. It was on lung cancer. I don't know if you've heard about it, but in 1 week, we were on the cover of the Wall Street Journal, palliative care, amazing. We were in the New York Times. We were in Times Magazine. We had kind of primetime media coverage because a study came out looking mostly at lung cancer, and patients who had lung cancer treatment and palliative care at the same time got more treatment, had better quality of life, and in fact lived longer. So this is what it's supposed to be. We're supposed to be feeling well so that we're strong enough to get more therapy. We also know that there's kind of these private things that happen, especially when we talk about gynecologic cancers. And these tend to go way to the bottom of the list. Like, it's not important to feel like a woman anymore. It's not important to feel sexually active. It's not important to feel attractive to my partner. It seems like in the big scheme of things, there's so much to talk about in your 5 minutes with the physician or your other care team members that it doesn't get talked about. And I know you have a special session coming up in the summer about sexual intimacy, but again, we can't do anything about it if we don't talk about it. It is private, but it's really important and it's part of who we are. The same is true for hair loss. Hair loss gets talked about because why? It's more obvious. People see it, and so people ask. But the other stuff is on the inside, and we have to bring it forward in order to make a difference. So loss of appetite can come from a lot of different things, right? We think about, is it because of the chemotherapy? Is it because I'm worried? Is it because my cancer is doing something to cause me not to be hungry anymore? Again, we can do lots of things to find out, why is it happening? What can we do about it? Sometimes it's a pharmaceutical approach with medicines. Often it's not. It's about changing things or even taking medications away to try to make appetite better. But it shouldn't be something that you just expect to accompany your cancer. Fatigue is a very, very big one. People think, oh my gosh, well, I should be tired. I have cancer and I'm going through treatment. Not so. We know it can come from blood counts. We know it can come from the run around of all the appointments and the sleepless nights and the worry and the anxiety. But all of those things we can do something about. Again, sometimes it takes medicine. Most often it doesn't. But it needs to be talked about. So if you're to make these lists, and I don't know if your doctors have ever done something like this with you, but if we went through all of these symptoms that we just talked about and said, rank these 0 to 10. You've probably all been asked about pain at some point, 0 to 10. But if you did the same thing for your appetite, and the same thing for worry, and the same thing for your bowel movements, to what degree are you constipated that you can tolerate or not constipated, or the opposite? And on a 0 to 10 scale, how fatigued are you? And we started paying attention to that. Often, when you're feeling really low, you find out that all those symptoms are pushed in the 7, 8, 9 scale, if not 12. And all of those things are things we can do something about. But sometimes just writing them down and keeping a list and bringing them forward and talking about it makes it better. This is another one that I hear a lot about, is chemo brain. And so interestingly enough, it used to be kind of this anecdotal, cliquey kind of thing that patients with cancer would report, but nobody really believed it. And they often felt like their providers didn't believe it. There's been research done, and now we know it's real. People say it's like living in a fog. It's kind of when the light bulb's ready to go out and it flickers, but it flickers when you want to read the newspaper, when you need it the most. So that's how people have described it. And look at that. 60% of cancer patients have experienced some degree of cognitive decline. Doesn't mean it's permanent. It's hard to know how long it lasts. It's hard to know even specifically why it happens. But we know that there is some evidence in short-term memory, that there's difficulty concentrating, that we struggle with kind of logistical things and kind of formulas and mathematics. Sometimes balancing a checkbook is harder than it used to be. So just knowing that it could be very real, and it doesn't mean it's Alzheimer's, it doesn't mean that we're going crazy and that we're never going to be the same again. It means this is part of the experience and what can we do about it? And again, we have to talk about it. So it's okay to say, I'm worried because I feel like I'm not remembering the things like I used to. Or when I try to do what used to be a pretty simple task, I struggle with it. It's okay to bring that forward and talk about, should we do some other testing to find out if something's changed? Or is it just hopefully a short-term side effect that we can continue to watch and monitor and at least feel normal about? So there's been a lot written here. This is actually from a book called Your Brain After Chemo, a practical guide, about how to kind of keep track of things. But if you look at this list, they're pretty reasonable things that we can squeeze into the day, but they're not things that we usually hold ourselves accountable for. We hold ourselves for higher expectations. We're not usually tender with ourselves about making sure we're doing things only we can control. We're not usually tender with ourselves about, kind of setting a reasonable time frame. We try to overcram our days and put too much into too little time. So now's the time to really just say, okay, this is all I can handle right now. Look at the big picture and focus on small things at the same time. It will get better, and it does get better, but it's that being tender to yourself along the way. This is interesting, the 60-60 rule, 60 grams of protein and less than 60 grams of fat. That's pretty easy for people to do. On the 60 grams of fat side, the 60 grams of protein is kind of hard to do, so you really have to pay attention to it. When I've talked to people who have tried to do that, focusing on 60 grams of protein, it becomes an interesting task of the day and almost something to conquer, which actually gives us some energy because we're getting more protein, and it makes us feel like we've accomplished something because we've kind of headed towards that 60. So something to think about. Within all of these things, the pain and the loss of appetite and perhaps the weight loss and the fatigue and the chemo brain, it makes us worry, in addition to the cancer. So cancer in and of itself makes us worry. And we live in a highly anxious culture to begin with, even without cancer. So when we add all these things together, we kind of have this mix of anxiety/depression, or is it a normal reaction to really bad news? Because sometimes it's just that. But without paying attention to how overwhelming it is, we wouldn't know. So saying I feel anxious about my chemo next week is one thing. Saying I can't think of anything but my chemo next week and I'm not sleeping because of it and I have headaches is very different. So even starting to ask yourself, if you're an anxious kind of person and you're feeling it, on a 0 to 10 scale, how is my anxiety today? We shouldn't have to live with 7, 8, 9, 10, or 15. We don't have to live with that. And what's really important in times of stress, especially during cancer treatment, is that, again, we're tender to ourselves and say, you know what, normally I know I'm a really strong person and I can deal with things. Right now, I can't. And just because in the past I have said no to perhaps cognitive therapy or behavioral medicine or a psych consult in the hospital, and I don't think I've ever needed to have medication in the past for my anxiety or my depression, now I just might. Doesn't mean it's permanent. It means that right now there's a limit to what I can tolerate. Because this will supersede, just like pain, anxiety and depression will supersede and infiltrate everything else and color the world gray or even darker at a time when it needs to be much brighter. So thinking about how do you know when it's too much? When is it dangerous to be sad? It's really about the consequence. If it's interfering with the quality of the day and the quality of your life, most of the time, then it's too much. So you probably heard physicians ask at some point, in the last 2 weeks, have you been able to do the things that you enjoy? We can ask ourselves that. Do I still enjoy the things I always used to? And my answer is no. Why is that? Is it because I physically can't do those things? Or is it because I just can't get myself motivated to do those things and they don't bring me joy anymore? That's a really hallmark question to ask ourselves. If we don't get joy from the things we used to get joy from, it's a pretty good sign that the emotional distress has kind of tipped the scale a little bit, and perhaps you could use some help with that. But at the same time, the second point on there is really thinking about what is normal. It is completely normal when you get bad news to react to bad news. And bad news doesn't always mean that the cancer is worse. Bad news can mean, I thought I was going to get chemo today and my counts are too low. That's bad news. Bad news can mean, I thought I was going to go home after treatment today and I have to be admitted. That's bad news. So reacting normally to things we didn't expect that weren't in our game plan is very normal. If that reaction becomes, intense and is interfering with most of our day, then it's a little abnormal, and we can probably use some help with that. Thinking about major depression, in fact, this is kind of a qualifying list, and I apologize, it's probably pretty small back there, but really you need a bunch of things to qualify for major depression. Sadness and reaction to bad news is normal and healthy. We should react to things we're not expecting or things that disappoint or make us sad. But if it lingers, if we're focusing on negative thoughts, if it's interfering with the way that we're able to function, we probably crossed a line. And so I include this just because I think it's helpful to kind of frame for yourself, is how I'm feeling normal, or is it too much and this is so different than the way I usually deal with things? We know ourselves pretty well. And so if we're honest and we say, I don't usually react like this, right? And how often during the day do we say, what is the matter with me? Because it means that we know something's kind of out of sorts with ourselves. But being tender at the same time and realizing it doesn't always mean something terrible. Sometimes it does. And when it's more severe, like a major depression, we treat that too. So this is just a bit about PTSD, post-traumatic stress syndrome. We're seeing more and more about it in the cancer literature, which is rather surprising. Usually we hear quite a bit about it when we think about our war veterans and people coming home from combat. But what we're finding in the literature is it's actually quite similar. In fact, there was a patient who has been treated in one of our Pittsburgh hospitals that has a piano in the lobby, who now can't listen to piano music because every time she hears piano music, it takes her back to her chemo days. That's a little bit of PTSD. We're not used to calling it that, but it's fair for us to know our own triggers. If there's something that makes things worse and sets us off emotionally, we don't have to expose ourselves to that. And if we do have to expose ourselves to that, perhaps walk through that lobby where the piano plays, then just acknowledging, I know it, I feel it, it's going to go away, and it's okay. And even just to say, it reminds me of, to bring it forward and say, what I feel right now reminds me of, because that's normal. And I think we're going to be seeing more and more about this as we begin to understand post-traumatic stress syndrome a little bit better. There's kind of some similarities between PTSD and anxiety disorders, which is what GAD is. It's generalized anxiety disorder. But the anxiety disorder is really more typically that. Not particularly triggered by anything. Nothing sets it off or makes it worse per se, where the PTSD experience might be usually defined by very concrete triggers, and we can identify them ourselves. And with both of these things, if you've never had this before and all of a sudden you have it, then all of a sudden you have it. If you used to be an anxious person but it wasn't too much and you could deal with it, and now it's too much, then now it's too much. So all of these things can be short-term. We deal with it because it makes life better. And like I said, I mentioned the study that was out last summer. We have very good evidence now. It used to be kind of what palliative care providers just said. Now we have evidence that if you feel better, you can tolerate more treatment, and the treatment works better. So if we think about, what to do about all this, because it's so hard to carry around. All of these physical symptoms, and now I'm worried, and, I just don't know if this is normal. So the fact that you're all here, you're already on a healthy track. You already know to reach out and be with people who have similar experiences. You all know that there are some things you can learn from others. There are some things that you can teach to others. And there are some things that are just so innately personal that you just have to kind of deal with on the inside and with the people who love you and care for you. The most important thing in all of this is to remember that it doesn't matter if you could deal with it before, if you can't now. Whether it's pain, whether it's anxiety, whether it's depression, whether it's fatigue, all of those things might need to be treated differently at different times in our illness. So this one seems like it's a little bit out there. Financial toxicity, this is kind of another side effect of cancer therapy that we're hearing a ton about. In fact, it's in the issue of Cure magazine that's over here on the counter for you. These numbers are from that article. Because I think as care providers, we don't pay a whole lot of attention to this, but it happens quietly and it happens privately, and it's very important. So between co-payments that are forever escalating, and prescriptions and gas prices and getting to and from appointments, that we think on the caregiver side, it's nothing to say, well, can you just come back on Thursday? Yeah, but I was here Tuesday and I was here Monday. Didn't you know on Tuesday you were going to want to draw this blood? So it becomes really burdensome. The treatment itself and the care plan can become burdensome. So if we look at that, bankruptcy rates increase 4 times within 5 years of a cancer diagnosis. That's really important for us to understand. Doesn't mean we can all plan for it. Doesn't mean we should all have a cancer savings account by any means. But it's important that we attend to it, and we are smart about how we're using our resources. And if we, again, compared to the general population, they're twice as high a year after diagnosis. So this is just some more impact, and again, this is in the Cure magazine over here for you on the counter. But this particular, Dr. Zafar said about $712 out of pocket for cancer treatment. Some of you in the room probably think that's pretty low. You wish it was only $712 out of pocket. I know my mom is a breast cancer survivor, and she needed to have IMRT, radiation therapy. Her particular insurance was a $40 per treatment copay. 8 weeks. 8 weeks, 5 days a week, times $40 a treatment. Guess what she said? I'm not going to do that. Well, it was get the treatment and do quite well, or don't get the treatment and leave that there. And so had she not been proud enough to say, I can't do this to her team, the other option was to just not show up, and they would have never known why. And in her chart, it would have said she was non-compliant, not that she couldn't afford her treatment. And so by bringing it forward, she was able to talk to the team, and the hospital and a bunch of other providers made some arrangements. So you have to make it visible. Because look at what else happens. 20% take less than what's prescribed of their prescriptions and their medications. 25% skip one of them. You know, I'll fill this one this month and skip the next one next month. 50% use life savings, and more than 50% cut back on food and clothing. This isn't what cancer was. We shouldn't let cancer do this. And we shouldn't let it happen privately for sure, because there are often things that we can do about it. Again, just like all of those symptoms, we have to make it visible. We can't help if we don't know. We have to kind of think about outside the box, and I think, so cast the net widely. Think about programs that you would have never considered before, and just ask, is there a program for this? Is there a discount for this? Is there a coupon for this? Again, nobody expected this to be happening in your life, so it's okay to reach out and ask for help. So that kind of takes us into how do we balance? You know, there's all this talk in the literature about work-life balance. And how do we manage stress, and how do we keep plowing forward and be optimistic and do everything at the same time? And especially for gynecologic cancers, and I don't mean this to be offensive to the men in the room, but women tend to overextend themselves. It's what we do, and we're usually pretty proud of it. And so when we're sick and we're tired, it's even harder to do that. But we don't say, I'm sick and I'm tired, so I'm not going to. Instead, we almost press a little harder. And so we have to be realistic about what really fits in. And now's the time, in fact, I believe every day is the time, to know for yourself, what does it mean to live well? And anytime anything gets in the way of living well, then bring it forward and let's work on it. Maybe it's an easy thing to fix, maybe it's not an easy thing to fix, but if it's not on your list of living well, then it deserves some attention. And that last point, learning to delegate and say yes, thank you, is really, really hard, especially for women. We'd rather serve someone else than, accept service for ourselves. So what do you think, and I'm sorry we're on tape, but what do you think the 3 most powerful words in the English language are? Sorry? Please, that's one word. Some people say it's I love you. Some people say it's I forgive you. So this particular author says it's please help me. That's a really hard thing to say. We're pretty good at saying, no, I'm fine, thanks. But it's a lot harder to say, please help me. And when times are hard, physically or emotionally or financially, those are the times to say, I need help. And that kind of translates into, what does it mean to be hopeful? Because of the kind of medicine that I practice, people often say, oh, don't talk about palliative care because it'll take their hope away. I will tell you, I don't have the power to take anyone's hope away. I could say something hurtful. It doesn't necessarily take hope away. I heard that there were some nursing students in the room, and I could say, oh my gosh, you're never, ever going to pass your boards. You go do retail or something because you're never going to be a nurse. And that would be hurtful, but they can continue to hope to be the next Florence Nightingale. So I can say to someone, you know, by looking at the papers and the tests and the numbers, this cancer looks really bad. I'm not feeling good about things. And you can continue to say and hope, well, I'm going to beat this. So hope is very personal, and you own it. At the same time, if you're not feeling well and you're tired and you're worried and finances are tight, it's hard to find, what do I hope for? So sometimes just framing what do I hope for gives us kind of little tiny steps along the way. So maybe I hope my pain is better today. Maybe I hope that tomorrow I'm less tired so I can go to my daughter's dance recital. Maybe I hope that my next CT scan does show improvement. Maybe I hope that I'm able to schedule my next chemotherapy so that I can go to the wedding at the time that I went to next month. So I guess my point is there's always something to hope for. But I feel like when we talk about hope, we always assume that hope has to equal cure, and there's lots of room for hope in between there, whether or not cure comes. So we beat ourselves up, I think, sometimes by putting hope way, way up here that we couldn't possibly get there when there's lots of hope in between. So finding that out is kind of hard because, you know, we live in a culture that is very extreme. And it would be human to say, I hope I'm cured. Everybody wants that. But we have to figure out in the in-between extremes, where does our hope come from? Is it in the people who I love and they care about me? Is it in my values? Is it my religion? Is it through humor? What makes me feel hopeful about today and my future? And then also knowing, what are the things that decrease my hope? Is it a particular care provider? Is it a particular time of the month? Is it that I always feel worse on the day after chemotherapy? And being very aware of what those things are, and then learning how to either avoid them if it's possible, or deal with it in real time because you know it's going to get better, and counteract it with something you can hope for. So it really takes a lot of self-reflection in terms of, you know, making this happen. And this is really hard work if you're feeling sick and tired, right? I mean, even on a regular day that has nothing to do with your cancer and you're tired and you have a headache, you don't want to think about the problems of the world. So this requires us to feel as well as we can. So we need to really do it all at the same time. And so this is an acronym, and you know, I apologize, a lot of people don't like acronyms, but it's SPIRIT, and it's pretty relevant, I think. So S stands for spiritual belief system. Does not necessarily stand for what religion you are. It stands for where does your kind of belief and a connection to something bigger come from. For some people, it is directly tied to organized religion. But for other people, it's not. It's about, what do I believe in life? What do I feel connected to? What makes me feel valued? That P, personal spirituality, is sometimes more directly related to religion. Kind of, how do I live that out in my life? And if we take it a step further in terms of integration into a spiritual community, it doesn't mean that we're all going to have this really close-knit church family. Many of us will. But even those of us who don't can still feel very connected to something bigger. And learning what that means for yourself is part of that, you know, it's one of the things that contributes to hope. But again, this takes some energy. And when you're feeling sick and tired, it's hard to do that. So R would be ritualized practices and restrictions. So this is a big one if you spend a lot of time, if whatever your treatment plan is requires that you're in the hospital, because we take the opportunity for much ritual away. You know, people who get a lot of value from going to Bible studies and prayer groups several times a week, if you can't get there, then it's likely to not be as helpful. If there's a certain procedure or a certain ritual that you would normally do, sometimes you're not able to do that in an inpatient facility. Something like, I was caring for a patient once who was a Tibetan Buddhist, and she was very near the end of her life, and she had very specific things that she wanted done, like a window being open. It's not going to happen in a hospital. So we had to talk about that. What can we do instead? Because it was really important, that ritual for her. So if you know that in advance and you think about it, And we're not going to talk about advanced care planning, but if you are going to do your advanced care plan, your living will, you can include those things in it. These are the things that I need in my life to help me feel connected. And actually, all of our care teams should know that about us. We should expect our care teams to say, what do I need to know about you in order to help me take care of you better? Have you been asked that? Probably not often. But wouldn't that change things if the way we, the professional caregivers, knew you was really how we came at your treatment plan, based on what was important to you, what you needed in your life to feel connected, and what your limits were in terms of quality of life. So again, this takes a lot of personal reflection. And then as you think about those things, if you know these things about yourself, it's helpful to write them down, it's helpful to talk to your doctors, and when things aren't going well, and often at the end of life, it's really important that you have these things, because that's when times are often the toughest. So if you've gone kind of through this process and you know yourself that well, it's kind of like if you know it, share it, so that everyone can take advantage of that and provide it for you. So I want to talk a little bit about chronic cancer, and I think this is changing. You know, we used to have diagrams when we think about prognosis and how to predict, survival times after cancer diagnosis, and they are so different than they were even 10 years ago, because cancers that used to be pretty imminently poor prognosis are now chronic cancers. So it's not at all unusual for people to live with their cancer for 10 or 15 years. And so when that happens, when cancer stays for so long, it often means that there are some periods of treatment breaks, but there's a lot of treatment in there. So it's kind of that roller coaster of treatment, or you're thinking about hitchhiking from treatment to treatment to kind of get a little more quality of life or get a little bit more shrinkage out of the tumor. And some people have described this as kind of living on the edge. I know it's kind of hard to see, so it's really thinking about, yeah, we know we have to do this, but it's hard at the same time, and what is the risk? And are we going to be okay with that? And what can we personally tolerate? Very important to consider. And one of the things we have to do is that symptom relief. So just like I said, if it's outside of cancer care, it's a bad day, you have a headache, you're not feeling well, and everything just aches. You don't want to do that. You don't want to balance the checkbook. You don't want to try to think about where your kids are going to go to college. You just want to kind of rest. So if symptoms aren't controlled, everything else is bleak, and quality of life will be impacted. So symptoms are the place to start. It's not all about symptoms, because certainly we want to treat the cancer and we want to pay attention to it. But for someone who's hurting and sad and worried and not sleeping and not eating, those things are just as important, if not more important, than treating the cancer itself. And so the way you get extra symptom control is certainly in talking to your healthcare team, making that list of these are the things that are really in the way of me having a great day. And what can we do about these? Sometimes your healthcare team can do that. They can just kind of look at the list and all of a sudden it's kind of visible and they can come up with a treatment plan. Sometimes it means an extra referral to palliative care, someone to specifically focus on the symptoms while the cancer team focuses on the cancer. And almost all of our care locations, at least here in Western Pennsylvania, have access to palliative care. And anyone can ask for that. It does not mean it's pre-hospice care. It means I need to feel better so that I can deal with my cancer. And so part of that is just kind of this support during this chronic phase. And so chronic cancer is a little bit different. We might obviously still hope that the cancer is going to go away. But mostly what we're hoping for is that the cancer is going to shrink, get a little better, have less evidence of disease, but it becomes at some point less likely that it's going to go away completely, and so we're hoping for a response. And then we celebrate that. So sometimes just knowing what is it that we're hoping for can help you frame things as well. So I don't know if you can see this. This is a little bit hard, but when we talk about this palliative care model that I mentioned, it used to be that it was either you had curative care on top or palliative care on the bottom, meaning care that was focused on your comfort. So if you look now, here's this wavy line, because the reality is our needs change. There are times when I'm feeling so healthy and robust, I want to fight the cancer no matter what. And there are other times when I'm feeling less healthy and robust, and I just want someone to make the pain better. I just wish I wasn't so tired. And I'm still going to fight my cancer, but now I really want to focus on the pain and being so tired. And then a month from now, I'm feeling better. So the experience waxes and wanes. That's why we have to rely on each other for you to tell us your story and us to be able to respond to that story and what's so important to you. So even into survivorship, we tend not to think about symptoms and quality of life in survivorship because it's a period of survivorship. For one thing, it's getting harder and harder to even define survivorship. I know for a long time I participated in Cancer Survivors Day, and we would do a thing at the end and say, 20 years or more, 15 years or more, 10 years or more. And when we would get down to 1 year or more survivor, 1 year or less, people didn't know if they were supposed to stand up because we're not sure. And so the reality is if you're living with cancer, you are a survivor. If you look at the research literature, it might talk about numbers of years disease-free. Personally, it shouldn't matter. It's that gray zone. If there is no evidence of disease, most people continue to worry about evidence of disease. My aunt was a 32-year breast cancer survivor, and we had Thanksgiving together, and we do this Native American tradition with beads, and one of her beads was, "I'm so thankful to be this far out of my breast cancer." And she died a month later from not breast cancer, from something else. So we just don't ever know. So it's really important to think about, even during survivorship, it's very confusing, and the worry and some of the symptoms can still be there because some of the treatments we had for our cancer could have, in fact, lingering side effects. And so just like we do during cancer treatment, during survivorship, we have to make those things visible. We have to continue to talk about our libido. We have to continue to talk about our pain. We have to continue to talk about how tired we are. And it doesn't matter that we're not getting cancer treatment anymore. It doesn't matter that they can't find cancer anymore. It matters that these are the things that are still present, which is why we're starting to see more and more about survivorship clinics, because it's very real. The experience of a cancer survivor is very different than the experience of someone who's going to their PCP that doesn't have a cancer history or diagnosis. And so we're learning to be more attentive to that, but we have to also make it okay for survivors to say, I still have these issues, and I would still like to attend to them. One of those issues is fear of recurrence, that worry that it's always going to come back. While it sounds contrary, it's sometimes helpful to make a list of the things we worry about. Write them down. And then think about, when was the last time this actually happened? Often we're worrying about things that either haven't happened yet, or it has been a very, very, very long time since it's happened, and there's a good reason why. And something happens, it's a phenomenon that once we write it down and we really think about it cognitively instead of emotionally, it's a little easier to deal with. And then you can kind of keep it on that list. And it doesn't mean you never go back to the list and it never crosses your mind again, but just to know that it's on one of the things that freaks you out, it's one of the things that's a bit too much, can help us start to deal with it. So what about deciding to stop treatment? People say, sometimes as a palliative care provider, when should I stop? The reality is there's no right or wrong time to stop. It's a very personal decision that's made with a care team. Some people will stop early and say, you know what, it's not on the cards for me, I don't want to get treatment and this is why, or I just, people have all kinds of reasons. Some people will choose to get treatment for as long as there's a care team that will give them treatment. And there's a wide extreme in there, and not one of them is right or wrong. So it's very important that you decide together, what's most important to me? So let's think about, let's say what's most important is being home with grandchildren and able to garden. Being outside is the most important thing to this person. And so it's time to think about another treatment option, and that treatment option is going to require a hospitalization every other week for 10 weeks. And in between those every other week's hospitalizations, they're likely to be pretty sick. They're probably going to have to come in and out for blood products. So that has a very great impact on this person whose quality of life is very dependent on being at home with family and being able to be outside. So for that person, they might decide that's not the treatment plan for me because I couldn't tolerate that. I couldn't have access to the things that get me through the day, so I can't do that. Sometimes it's, if my goal is to see my daughter get married next summer, If what is being offered helps me accomplish that goal, then I might say yes. If what is being offered is unlikely to help me reach that goal, I might say no. So again, it all starts with self-reflection. What is important to me? What do I need? What do I see in my future that is hopeful? And that's how I make my treatment decisions. Sometimes that gets people to, yes, I want to continue treatment. Sometimes it gets people to, no, I don't think I want more treatment. Very personal decision. And then there's kind of this question about how much am I willing to tolerate? Whether it's pain, whether it's financial expense, whether it's being away from home. We have very different levels of tolerance. So just knowing I can handle that because it's only going to be 3 weeks, I'll do that. But if there's no endpoint, then I might not be able to deal with that. So kind of knowing what our personal limits are. And then asking that scary question, if I don't, what are the consequences? And then you get an answer. And again, then it becomes a very personal decision. And then back to those questions about what's most important. What's most important in all of that, in terms of stopping cancer treatment, is that it doesn't mean stopping care, ever. Stopping treatment just means we stop a particular intervention. The rest of everything that's included in care should continue. And so we shouldn't have to be afraid of that. So when we're thinking about that, not even just in terms of stopping treatment, I can't think of one person ever, no matter how young, how old, how healthy, or how not healthy, that shouldn't be thinking about the future, because we just never know. So who is it that's going to make decisions for us if we can't verbalize our own decision? What would those decisions be? Who's going to know who that person is? Should we write it down? Should we talk to our doctor? How would I even decide this? How would I know if surgery in my future is the right thing or the wrong thing? Or if dialysis is going to be helpful or it's not? I'd have to have that conversation with someone who's responsible and who knows my medical history. And guess what? These are really hard questions too. And when you're not feeling well, it's harder to think about these things. So as contrary as it sounds, these are the things that we want you to be feeling as well as you possibly can, so that you can think clearly and brightly about the future and what's most important to you personally. So this is a quote from Mother Teresa. It's to keep a lamp burning, we have to put oil in it. And so this is really about self-care. And everything we've talked about tonight is really self-care. It often depends on your care team participating in that care plan once you share, what's going on. But if we don't take care of ourselves, it's really going to be hard to get through anything, especially cancer. And so there's another quote that says, the heart must first pump blood into itself. So the heart, if it doesn't have blood, it won't pump. There's nothing, it has no purpose. So if we think about that, and we have to keep our heart pumping, and we have to keep our lamp burning, we can't do it if we're not feeling well. So I want to, if it's okay, I was hoping to show just another 1 minute of that video. Is that okay? So were there thoughts or questions about anything we talked about? Right. So the nurse in me says always talk to the nurse. But I don't think that's true always either. I think depending on the practice, you can do different things. The world has become so techno-savvy that maybe you say, can I email my list of things to somebody the day before my appointment? And can somebody look at it when I get there? Or these are my list of 5 things, but the top 2 are really what I want to talk the most about. Or maybe it's as soon as you get there, you get, when you check in at the desk, you give somebody the list of that stuff so that when they get your chart, the list is already on there too. And so I think you just kind of figure that out. And I know that's really not a specific answer, but the important part is it has to get brought up somehow. And, sometimes it's if you don't have time to talk about this today, can you call me later tonight, or can we talk about it tomorrow or the next time I come in if it's not urgent? The other thing that often works very, very well, and again, you have to know yourself, but to bring your tattletale with you to the doctor, because it's so tempting to, when the doctor comes in or the treatment team comes in, to just say, oh, I'm fine, because you want to move on with things, and they're busy, and you don't want to take up too much time, and you're afraid to complain too much, because then they might not give you treatment. But if you bring your tattletale, and I am my dad's tattletale, so I say, oh, that's not true. He didn't even eat. or he's lost 5 pounds, or he's not sleeping. Or can I just tell you that he can't afford that prescription that you gave him the last time? So you have to know yourself and what you're brave enough to bring up. And then you have to know your treatment team and what's the best way to do it. And sometimes just asking. Just say, should I call the day before? Should I send you my list? How can I do that? To really establish those modes of communication. And as busy as treatment teams are, I've never had a treatment team that's not grateful for that information. It's just, sometimes it doesn't come up in the course of a visit, so if you bring it up, it has to come up. But email has turned into this kind of, like I said, it's a techno-savvy world, and a lot of patients will email the day before, these are the things I want to talk about at my appointment tomorrow. So something to think about. Well, it's a very personal perspective. So there are many, many people who say, yes, I'm a very spiritual person, and I believe in a higher power, and I pray, but I'm not a religious person. Some people will say, I'm a very religious person. I do that, I'm this religion, and I do the rituals of my church, but I don't consider myself a spiritual person. So, that's why they start to blur in terms of the organization of it and where the not benefit, but where the kind of positive feeling comes from. If it's a personal thing or if it's external, is kind of how some people think of spirituality versus religion. Religion being mostly external and belonging to an organized group, and spirituality is what you own on the inside that may or may not be connected to an organized group. Which, and what we see is just an interesting dynamic. I'm glad you brought that up, because often we will see people say, would you like to see the chaplain? Oh, no, I don't need to see the chaplain. But when someone comes in and says, hi, my name is so-and-so, and doesn't say, hi, I'm the chaplain, they can have a lovely conversation with the chaplain and not even know that they had a chaplain visit, because it's what we kind of label in our head and how we see the world. Anything else? All right, well, thank you for having me.